Hey there and welcome to Concierge Medicine Radio, your source for actionable advice and real stories of physicians running and growing concierge practices. For more interviews and notes on today's show, please visit conciergemedicineradio.com and enter your email. Now, let's join your host, Taylor Pearson.
We're joined today by Dr. Qamar, founder of Medlion, one of the first direct primary care companies in the nation, and more recently the founder of Medlion, a new product to facilitate the growth of telemedicine in primary care. Dr. Qamar is an expert in the fields of membership practices, VIP medicine, and direct primary care, and has studied medical models from around the world. So thank you for joining us today.
My pleasure. My pleasure.
So tell us a little bit about your background and Medlion and what you're up to.
I'm the product, when we talk about background, of a United Nations family, and my father was a senior diplomat for the UN. We lived around the world for all of my childhood, and when it came to stateside, the Washington, D.C. area was home to me. But I had an opportunity as a small child to see healthcare systems all over the world as a patient and experience care in socialized medicine and privatized medicine throughout my childhood. When I eventually finished my training in Pennsylvania in family medicine at the Lancaster General Hospital's program, which is one of the country's first in family medicine, I was exposed to the current system of healthcare in residency, which didn't agree with me too well. And so from day one, literally, of residency, I had decided to start my own practice, and I found at that time that the only practice model that suited my style, which really had to do with spending more time with patients, was a field called concierge medicine that was starting to creep up in the early 2000s. I created then, from scratch, a concierge practice in Monterey, California, because my wife was from California. She's also a family doctor. And we moved from Pennsylvania to California on the coast to start the area's first concierge practice. Within just about 6 weeks of getting there, I became the house doctor for the Pebble Beach resorts and amassed a very nice patient list of celebrities and Hollywood stars who became my friends and my patients, and ended up launching what became eventually as one of the most expensive concierge practices in the country. In the meantime, my wife, again a family physician, had launched a regular traditional insurance-based practice. And so for several years, we were in a very nice position to compare the advantages and disadvantages of each. When the economy hit in 2008, my practice didn't suffer so much because of the net worth of my patients, but my wife's did, because in this great country, health benefits are tied to employment, and during the start of the recession, unemployment was on the rise. We noted that a lot of her patients had stopped coming in because they had to pay self-pay rates when they were in fact losing their homes. So they tried not to come in. We then decided to use the experience, the knowledge, the expertise that we had derived from creating a membership-based medical practice for my concierge practice and see if we could apply that to a wider sector of patients. In this case, my wife's patients who were now unemployed and uninsured. That's where Medlion was born in 2009. We did it as a way to help the unemployed population of Monterey County, and it started growing very quickly with patients coming in, not just from within my wife's practice, but from around the state, who were now looking for an affordable way to get primary care, which is by and large the majority of the health care they needed. We then started looking around the country to see who else was doing this. Nobody else was doing it in California, but we did find several other companies around the country, some out of Washington State, some on the East Coast, who were trying to do similar things. And we realized that there was now a potential for us to actually scale what we had done in our own clinic around the country. Between 2009, yes.
Just to give listeners some context, what were kind of the years? When did you start practicing in Monterey originally, and then when did you start Medlion?
Yeah, so we started practicing in Monterey in 2006. That's when I had formed my concierge practice. And we were actually still practicing concierge medicine when Medlion was created in 2009. And it it is what financed a lot of Medlion. The concierge practice was very expensive. The fees were as high as $30,000 a month for a family. And a lot of those fees were taken to fuel Medlion's growth as a practice model. That started in 2009. And as time progressed, we got more and more calls from physicians around the country who started hearing about this new way of practicing where you could really take care of patients directly without having to deal with third-party payers and all the hassles that come with it. And our model now had gained a lot of interest in the media. We started growing around the country. Today, 4.5 years later. Yes.
I want to walk people through, or
Sure.
walk myself through as well, kind of the initial startup phase. So how is Medlion structured? How does it differ from other direct primary care practices or corporations doing direct primary care? And then talk to us a little bit about how you launched it, how you grew it, and maybe that initial 6 months or a year.
Yes. So we had several advantages on our side, Taylor. The number one being that we had an existing, very expensive concierge practice that was already working for us. So that ended up fueling a lot of the financing part of it. The other thing was that my wife, in whose practice was the first Medlion practice, she already had existing patients who paid via insurance. So in a sense, it was a hybrid practice model from day one. We considered that to be important, and it wasn't done by design. It's just the way it turned out. But it did lend to solvency from day one. We were able to fuel the cost for that startup for Medlion's practice with the hybrid approach through her insured patients. And, of course, we had my separate practice, which was the concierge practice, also paying into it. It grew only within her own patient population to begin with. We didn't have to do much advertising at all. Word of mouth was the biggest thing. And as word spread about the service at this affordable cost, we slowly started getting more patients. It didn't happen overnight. Growing a direct primary care practice can take a long period of time. And the reason for that is even though the doctors now understand how the model works and its appeal, society is still conditioned into thinking you need health insurance for all health care. And the concept is very foreign to society at this time. So it does take quite some time to grow. It took a long time for us to grow to even several hundred patients. It took literally over a year and a half. But during that time, we were able to do a lot of research on the direct primary care model, do a lot of experimentation with advertising and marketing and so forth. So to answer your question about how we grew, word of mouth was the number one thing. Then, as we realized we were onto something and we could fuel the growth with perhaps more advertising, we experimented with everything from TV ads to radio ads to billboards to salespeople going out in person and so forth, and came up with sort of a best list practices as to what worked for us. When other doctors started coming to us, that was sort of the advice we would give them, and that's how Medlion started growing. It was a grassroots effort for direct primary care by local doctors who were trying to do something for their community, and that's how we continue to grow today.
So walk us through those best practices. What's kind of the Medlion recipe for a successful direct primary care practice?
Well, I think expectations is number one. If you have very high expectations, that's a setup for disaster. Most physicians who want to seek a better way to practice, usually through direct primary care, are already burned out or are frustrated with the current system. It's why they come to us. If they think that it's easy to grow a patient base of pure direct primary care patients within a year or even a year and a half, they can be very easily disappointed. Again, the factors that drive patient growth aren't just the uninsured anymore, it's also employers. And these are the types of folks who are not used to going directly to doctors for payment. Usually it's through insurance companies. And so when you have to fracture insurance away from primary care, that new concept does take time to take hold. And in this country, the culture currently is that we expect our employers, if possible through the employer mandate, or the government to pick up the healthcare tab, if possible. And it's very difficult to hold patients accountable when it comes to signing up with Medlion. So when it comes to best practices, there are various models that exist at Medlion. We are now in 16 states. We represent physicians in 16 states, and with the advent of the Affordable Care Act, that actually has an amendment within it that includes direct primary care. We have lots of employers that are coming to us now. We have individuals that are coming to us now as well. And the practices on how quickly you grow, how well you grow, differs from type of practice to type of practice and from area to area. So case in point, if you take, say, Las Vegas, for instance, where there's a lot of unions, a lot of trade associations, your growth might be one way, as opposed to Monterey, where we started, where you could actually get patients through direct advertising. We have found that it's more efficacious for us to go through employers. That is not as easy for solo direct primary care practitioners to do, because employers tend to listen to their own brokers. They tend to listen to benefits consultants.
Well, how is Medlion different from some of the other corporations or organizations out there that are doing similar models?
Yes, good question. So there are lots now of companies trying to do this. We have some of the pioneers that I will be happy to name. There is Medlion, of course. There is Q Alliance that actually helped coin the term direct primary care. There are solo doctors like Dr. Brian Forrest of Access Healthcare out in North Carolina, who has been doing this for a long time already, and others who now are getting funded by venture capital to do this. Medlion does things a little bit differently. We, in addition to becoming a direct primary care strategy organization, we license our Medlion model directly to independent physicians around the country, i.e., we don't hire our physicians on an exclusive basis at this time. Some of our competitors do, and that's great for doctors who wish to be employed, but our philosophy at Medlion is that we feel that the independent primary care physician's stature is starting to falter because of influence by the insurance industry and the hospital industry now, which are buying up practices. We would much rather try to help them stay in private practice. And so we give them strategies to use Medlion's formula in their own practices. We give them strategies in how to keep overhead low and survive in this type of environment. And we don't charge the physicians for that at all. We simply do this as almost a favor for them to keep them in a direct primary care network. Where Medlion ends making revenue is from the employer side when we sell them the benefits plans for primary care to be able to partake in these types of situations. That's how Medlion is very different. We don't like to hire physicians. We feel that it's more important to empower them. We can go into existing practices and flip on a switch and create a hybrid DPC/insurance-based practice overnight. We have that capability. It's what's allowed us to scale very quickly around the country. When we have national accounts with organizations like IHOP and McDonald's, like Denny's, who we actually do have on our list of patients, we need to have the capability to go into an existing practice, teach them what direct primary care is, and let them know that in the surrounding area we have employers that are now willing to see them, and we're able to do that very quickly. So we're very flexible with how we can grow. We do have the capability to hire physicians. In fact, we're in the process now of creating on-site clinics for several resorts on the East Coast, but we believe by and large that we have to license this model to existing physicians to get them to adopt this model as soon as possible.
Well, walk us through how that works then. Let's say, so I'm in Austin, Texas. Let's say I give you a call and I say I want to practice direct primary care. What happens at that point?
Yeah, so we basically have a conversation. That's the first step. I personally get involved with every single contract that's signed, and we try to speak to the physician to see what their goals are from a practice standpoint, from a personal standpoint, and see if we're a good match. We educate them on what services Medlion provides for them, such as either providing them volumes of corporate patients, making sure that the direct primary care practice is in compliance with the state that they're in, something that we do very well. And, of course, we do all the back-office work so they can practice medicine. A lot of doctors would love to practice in the DPC environment without having to work with the billing nightmares that take place. We have very sophisticated billing systems that can literally deal with millions of patients every month if we had to, out of payroll deductions and so forth. So we put all that into play and to work for these physicians. We're pretty well recognized in the media. We're one of the most well-recognized direct primary care companies in the U.S., so we're able to use that to our advantage to help these physicians also grow.
To kind of summarize what you said, then you're providing the back office solution in terms of all the administrative work, and then you're also bringing in patients through your contracts with employers.
That's right. I'd add to that the legal component as well, which is important. One of the biggest threats to not just direct primary care, but also concierge medicine is whenever you charge a monthly subscription and provide then medical services, if it's not designed properly, it can be misconstrued as insurance. And that is a very important thing that we have to decipher and have done a lot of work with in various states to ensure that our doctors are in compliance. So that's a big factor that we have. And in addition to that, it's not that you set up just once and let it just ride. Laws are continuously changing, and we have to stay abreast of those. We have a legal department, which is probably one of the best ones in the country when it comes to direct primary care. We've hired attorneys who have worked at the Department of Managed Healthcare in California, which is one of the toughest states to do this in, and we make sure they're in full legal compliance. But yes, to answer your question, it's legal, it's back office, billing, customer support, management, explanation of DPC. Then we also do the strategizing of putting various types of real insurance products together with non-insurance primary care products like Medlion, and we sell that with our existing sales relationships around the country to employers directly.
Well, you mentioned there was kind of a learning curve here for Medlion. I know anyone looking to move into direct primary care, they have that same kind of learning curve in terms of how all the different systems work, and as you mentioned, there's like state-by-state basis regulations. So what are some of the mistakes either you've made or you've seen other people make, and how can they be avoided?
That's a very good question. I think the learning curve for Medlion and for some of the other pioneers that started out in the beginning was a lot steeper because there was really nowhere else to go for education, for research, for knowledge. We actually had to create the model from scratch. We had to do our own research. We had to make those mistakes. I think today, if we had started Medlion 5 years later, there's a lot more information that exists in the direct primary care industry. First of all, the term direct primary care is a little bit more ubiquitously used than it was at one point. There's still a lot of confusion between DPC and concierge medicine, but by and large, a lot of folks have now heard of direct primary care, which helps a lot. You have a lot more doctors who are now in practice who have made the same mistakes that Medlion's made, so it's easier to go to them for advice. And a lot of states now, several states have passed state law. The Affordable Care Act has actually got direct primary care in it. All these things were non-existent when Medlion was first formed. But to answer your question, some of the mistakes that we see physicians making, because we do help all of the doctors right now who work with us are independently owned practices, the mistakes that we have seen are that doctors sometimes forget that when they start a direct primary care practice from scratch, they have to exercise the same business principles that it takes in setting up any new business, whether it's an insurance-based practice, a donut shop, a garage. It's still a business. So it's crucial to keep overhead to a minimum and to take as much as you can in terms of revenue to keep cash flow positive in the beginning stages. We believe that hybrid practices tend to fare better because there's positive cash flow from day one. Sure, it'd be great if a direct primary care practice could sign up, a critical mass of patients to pay all the bills overnight, but that doesn't happen. It's very rare that you have any business have a full customer base overnight to pay all the bills. It's still a startup phase that they have to endure. So to answer your question, we have found that the doctors who do this and expect it to grow overnight become very disappointed very quickly. This is a long-term solution to your career and to the practice, so you have to think of it in a long-term fashion. And we have found that it can take years before you hit the nicer numbers, which can be quite rewarding. I think that's something that's the number one piece of advice I would give the doctors is.
So what do you think are realistic in terms of expectations?
I think it depends where you are. If you are in a very small town, it's easier to be a big fish in a small town. The demographics of the area are very important. The market factors here, I think, are not the uninsured population as a lot of direct primary care providers think. That's how it starts out. The uninsured population, as much as we want to help them, can be very unsustainable as a population to your practice model because as soon as they get an employer who will pay for benefits, which is coming up under the employer mandate in many cases in January, they'll split and they'll want the employer to take up the tab. So it depends where you are. If you're in a big city, if you're in a small city, if you're in suburbia, it also depends on what the cost of your practice is. If you're charging $100 a month, that might be cost prohibitive to some as opposed to charging $50 a month. You also have to then balance that with your office overhead. Now, if you have a very small micro office and you're charging lower fees, you can survive. But if you have a very large office and you have a high overhead but you're still charging lower fees, you won't survive. So there are many, many factors, and it's sort of hard to answer that question. But the key is to keep your overhead down, and I would say it takes about 3 years before you start seeing very, very strong traction with your direct primary care practice.
Okay, 3 years is what most people I've spoken to have said is a good benchmark.
Yes, that was our experience. Sometimes you get lucky, and you can get an employer to really understand the model, get their health resources department to understand it, and you can fill up literally overnight. In other cases, it doesn't. In most cases, it doesn't happen like that.
In terms of the hybrid model versus going straight to direct primary care, one of the big criticisms a lot of people have for the hybrid model is you don't get rid of the overhead. So if you're still having to deal with insurers, you're not eliminating all the overhead associated with that. So what would you say to those people?
They're absolutely correct. What we also say, though, is that most doctors going into direct primary care understand the wonders and the advantages that direct primary care brings. What we say, it's impractical to think that society will jump into DPC as quickly as physicians will. Again, we're having to recalibrate society's thinking in that it's okay to pay for primary care separately from insurance. That takes time. It's very difficult to change a culture overnight. People will revolt if they are exposed to something new when they're so used to working with what works. Even if it doesn't work as well for them, they'll still stick to it because they're comfortable with that concept. The moment you come in and try to separate the whole concept of primary care, which, by the way, is still not, primary care itself has become a mystery to most patients now. We feel at Medlion we have to explain what primary care is and then explain what direct primary care is. It becomes difficult. So they're absolutely right. You still have that overhead, but it's very difficult to introduce direct primary care as a 100% model from day one when most of the country actually has insurance and wants to use it. So we say to them, our goal, anyways, at Medlion is not to make you 100% direct primary care from day one. We think that's impractical. Our goal is to reduce your dependence on third-party payers and associated hassles from day one. And then as time increases, as the culture changes towards more acceptance of DPC, and we've seen a lot of acceptance take place already in the past 5 years, as that trend continues, the goal is to then slowly and slowly fill in your practice more and more with direct primary care and replace the insurance contracts that you have as time continues. Direct primary care is not going to take over the primary care industry of this country overnight or even in the next 5 to 10 years. It's going to take a lot longer than that, and that's what we try to work with.
So walk us through, I'm interested to learn more about kind of how Medlion approaches employers and how they negotiate those agreements. It certainly makes sense to me if education is kind of the biggest hurdle here, educating one person or a small group of people in, say, a human resources department versus trying to educate every single person coming into the practice, you're going to get a lot better returns by approaching those employers. But what do you say to employers? Walk us kind of through the process of how you approach those and show them the value of direct primary care.
So you're absolutely right. Education is the number one obstacle here. Everybody thinks that health insurance is in the business of healthcare. That's not true. Health insurance is in the business of insurance. Doctors are in the practice of healthcare. And so we have to decouple that mentality when it comes to primary care being associated with insurance. The reason why people are dependent on insurance for primary care is because even primary care is expensive. If we can offset that by making primary care affordable, you wouldn't need insurance for it anymore. And because the events that occur in primary care are predictable and in terms of cost, it's very easy to say then you don't need it. So that is the number one message we give to employers and to society when we educate direct primary care. It's no different from teaching our patients who walk in off the street the advantages of direct primary care versus teaching the sophisticated employer as well. We have to educate them on what primary care is, why you don't need insurance for it, and because primary care comprises the majority of health care needed and sought by employees, capping that cost off at a limit every month per employee is of extreme financial benefit to that employer. That's how we start the conversation. And it always works when you can take claims data from the previous year, look at the primary care component, and you compare that, now you're comparing apples to apples, and you can tell them, well, this is how many claims you had for primary care last year. Imagine if all this was limited per month by this X amount, and that's where now they start seeing the benefit. The cooler thing about direct primary care is that the medical care is actually better care. And it's not that the doctors are better trained, it's just that the access that is given to patients in a direct primary care environment is more enhanced. So because the doctors take care of fewer patients, you have same-day visits, next-day visits, you have a lot of telemedicine, and Medlion, as you alluded to earlier, has also gotten into telemedicine technology as well to enable that. But that type of rapid, extreme access combined with longer patient visits does amount to more empowerment of healthcare with that patient, with that employee workforce. So they then start seeing decreases in claims for specialist referrals and hospitalizations on the other end, which is where a lot of their money goes also. You put all that together, and then the employer starts getting how this model could actually work. It's not easy. It takes a very sophisticated team of doctors, of health insurance professionals, of benefits professionals to come together to persuade a company, which has to be open-minded as well, that direct primary care is not just a new model that's experimental. It actually works and has been working for other companies.
I certainly understand from a company's perspective that is this, some new fad? It's not something that's very legible to them. So what do you show them in terms of evidence or proof of the model, and it's both how established it is and how effective it is?
Right. So the model is actually not so new anymore. It was at one point, but it's new in the sense that employers are still learning about it, maybe new to them, but there are some very large employers which now have adopted this. We deal with employers who have national chains across the country who are not doing this. So we give them testimonials from a lot of our existing clients, for instance. We give them testimonials from other patients as well, the employee base who we constantly look at for feedback. We also show them the law, where it is in the Affordable Care Act, where it is in certain states' laws, and so forth, so that there is greater comfort with trying something for them which may be new, which is not as new for others. And that helps, I think, quite a bit.
Projecting out, I want to step back and take a little bigger picture view here. Projecting out 5 years from now, what do you think the U.S. healthcare industry will look like? And, from the perspective of a physician, how would someone position themselves, or what steps can they be taking now to be somewhere in 5 years from now that they're going to be well positioned to handle the changes in healthcare?
I believe, and I think some of the DPC pioneers agree with me, that direct primary care is now headed into the mainstream primary care culture of the U.S. We're still a long ways from penetration across the country, but with support from national organizations like the American Academy of Family Physicians, the fact that we're in several state laws and we're even in the federal law, this is a model of healthcare which you're going to start seeing to grow very quickly. Concierge medicine grew quickly too, and I know this because I remember giving a lecture in Lancaster, Pennsylvania on concierge medicine in 2004. I asked for a show of hands in the audience, and there were only 2 or 3 people who had heard of concierge medicine. Exactly 8 years later, I was asked to give a lecture at Hershey Medical Center, and same area, roughly, and so there were about 200 physicians in the audience. This is 8 years later. This time I again asked who had heard of concierge medicine. Everybody in the room had raised their hand. So within 8 years, the penetration of the concept had reached quite a bit. I asked how many had heard of direct primary care, and again, we only had 2 or 3 shows of hands. I predict that direct primary care is going to grow much, much faster than concierge medicine ever did. And the reason for that is DPC is in the fabric of American law now. Concierge medicine never had that privilege. Number 2, you can actually provide direct primary care at an affordable cost, which can now be sold to employees very easily. That is also something concierge medicine could never do. And you're now able to reach a wider audience through the employer market. You're going to see this growing faster because in this country, as we talked about, employers are now responsible for providing a lot of healthcare benefits, especially under the employer mandates. They're going to look for the cheapest option, and that affordable option is going to be direct primary care in many cases once they're exposed to it. So to better prepare yourself for what's coming down the road, for physicians anyways, I would say it'd be wise to start looking into this model to see how you can implement direct primary care into your practices at this time, reducing your dependence on third-party payers, whether it's the government or private insurers, because quite frankly, if you can provide care, high-impact preventive and primary care at an affordable level to employers directly, employers won't need anybody else.
Another criticism I've heard, I'm interested to hear how you would respond, is by bringing the employer into the mix, there's a possibility here that you're going to move away from patient-centered care, which is if the employer's footing the bill, aren't you just working for the employer now instead of the insurer as opposed to the patient?
That's a good question. It depends on how that employer is structuring the contract. If the employer is simply paying for it and their only role is payment, they don't really control the health care at all. They just control the cost. And the cost, by the way, is not determined by the employer. The cost is determined by the physician organization contracting with them. So I'll give you an example. We just signed up at Medlion, a very large taxi company in Las Vegas. Hundreds of employees and their dependents are now on board. They wanted to pay 100% of the primary care benefit, and so they did. They don't guide us when it comes to how we should practice. They don't tell us what they like, what they want. None of that. All they do is they foot the bill for these employees who they care for and their dependents. We were the ones who set the price for that, not them. So we now, on our own, have to make sure that we really go out of our way to provide very good, high-quality primary care to these employees and their dependents. Because if we don't, we are held accountable by the employer who's going to ask these employees, are you happy with the care you're getting? If they are not, the contract will not be renewed the next year. So we're not really working for the employer, we're working for our patients. And if we don't do a good job with them, they'll simply go elsewhere for care. That's the cool thing about the direct primary care model. We are held accountable to our patients. Now, when it comes to other situations, we're even more accountable to our patients when they participate in the cost. We have some employers who only foot half the bill. We have other employers who don't put any part of the bill, they just offer it to their employees. In those cases, which are called voluntary benefits, those patients end up paying out of pocket themselves to get the Medlion services. And again, we are held accountable to them. I think the situation changes, though, when you have not the employer invested in this, but investors. If Medlion was funded by venture capital and investors who are non-physicians held the majority shares in the organization, that's then who Medlion becomes accountable to. And we didn't want that. It's why we didn't seek venture capital from day one. We felt that it was important for us to be held accountable to our consumers and not to investors. But that's how we look at the whole employer relationship. The employer then becomes a consumer of healthcare, and they're in one unit bunched together with their employees who together see what the best option is for healthcare. We're responsible to them.
Well, let me steer you away from Medlion then and talk a little bit about telemedicine. I know you have a new product called MedWand. What role do you see telemedicine playing going forward with primary care, and how does MedWand play into that?
Telemedicine is an interesting thing. Technology has advanced quite a bit, where we now have the capability for video conferencing much more than we always did. Texting has become commonplace now. Something we take for granted wasn't even around 15 years ago. And so those types of things that have come about now have eased, if you will, barriers of communication between doctors and patients. It doesn't mean, though, that doctors will readily accept those modalities of communication, because there's still problems with reimbursement. In an insurance-dominated healthcare industry, doctors are paid by and large when they see the patient. They don't get paid for telemedicine in most cases, and if they do, it's minimal. A doctor is not incented then to practice telemedicine in a way where they actually can make money off of it, which is bad, because telemedicine can be quite a nice thing. In direct primary care practices and in concierge practices and in other models where you have a per member membership for this medical service, the doctors are no longer forcing patients to come in for unnecessary visits. We do a lot of telemedicine at Medlion, for instance, about 30% of the time, because we feel that not all visits are necessary. If a person is having a sinus infection, the same kind they've had for years, why do we consider it necessary for them to come in if they don't have no dangerous symptoms? The reason that most of these patients are forced to come in an insurance-based practice is because that's the only way the doctor gets reimbursed. So the patient comes in, they do a little exam, then they bill the insurance company, which in our opinion is just a waste of resources, and it's even a waste of the insurance's claim money as well. It's also a big waste of the patient's time. And so in many cases, it's not necessary to call in patients for refills unnecessarily and so forth. Medlion, we actually pride ourselves with telemedicine quite a bit. We already did a lot of it by phone. When patients would call in, we probably spend about 30% of our day, and we train our physicians to also be able to handle telemedicine appointments. They can be very quick, and if they're trained properly in how to triage the important calls from the not-so-important calls, it's very easy to practice a lot of telemedicine as well. Our next phase was just a couple of months ago when Google called us and said that they had created a HIPAA-compliant online video platform and asked if Medlion would like to partake in that venture. And we, of course, said yes, because it's free for our patients and free for us who are part of Medlion. And now, if you are my patient, for instance, and you want to be quote-unquote seen remotely, you can tap in and you'll be able to be seen by a Medlion physician online, video conference to video conference, fully HIPAA compliant, and we could see each other and the visit could take place. But I wasn't convinced that was the best way to practice telemedicine. I think most doctors who practice some degree of telemedicine, when they take call for their patients, they know it's a big handicap not being able to examine their patients. I also believe it's a big part of the reason insurance companies' reimbursements for telemedicine are not as high, because there's not actual data which is obtained in an objective fashion from that telemedicine encounter. If you are a patient and you call in by a telemedicine appointment tailor, I can't examine you. You may say you have a sore throat, but I have to take your word for it. You could maybe get a little bit more sophisticated and take a picture of it with your phone and send it to me if we have that arrangement. And yep, I could see some, but wouldn't it be great if I could manipulate where I want to see in your throat to see the things that I am trained to look for? So I still can't do that. I can't get your temperature. I can't get your pulse rate. And so it becomes a little bit limited, and quite frankly, it's a liability for a lot of physicians to speculate over the phone or video conferencing as to what the issue could be. So I created something after I couldn't find anything on the market to be able to examine our patients at Medlion as well as take care of them by telemedicine. Now, with our device called the MedWand, you take it out of your pocket because it's pocket-sized. You plug it into your laptop or your desktop, and pretty soon you can plug it into your smartphone. And while I am having a video consultation with you, you can put it on your finger, and I can now listen to your heart. If you put it on your heart, I can listen to your lungs. I can get your full set of vitals. It even has a high-resolution camera at the tip, so I can look into your throat. I can look into your ears. It's almost as if I can perform a full examination remotely off of a Wi-Fi secure access feed. And you could not just necessarily be in the next town, you could be halfway around the world in Tokyo, and if you were to call in from there, we could take care of you from there as well. It's something that we decided not to limit to Medlion, so I created a separate company called MedWand, and we hired the nation's best engineers from some very big medical device manufacturing agencies. We put together a team, I did, and we are now creating this. That will be venture capital funded. We expect to be funded in the next couple of weeks, and it's going to be manufactured right here in America, in Silicon Valley. There's another plant we have in Alabama that's going to create it, and we expect that to have that in service probably by this January, and that should really turn up the volume, I think, of telemedicine, because now you'll be able to have doctors actually examine patients as opposed to just talk to them via audio and video. We're going to change the whole telemedicine industry with that.
And you think the growth of direct primary care is going to fuel this growth in telemedicine?
Absolutely. They have it now, and right now most direct primary care providers do practice telemedicine. It's now you're actually selling convenience to your patients when you can provide telemedicine, and a lot of patients really appreciate that. And moreover, in the direct primary care industry, it's sort of a free consultation in most cases, so patients enjoy that convenience aspect, and they enjoy the cost, and they can get the care they need without being troubled.
One final question for you. Looking back now at founding Medlion and your concierge practice, what's the one piece of advice you would give to a physician that's either thinking about making a transition into concierge or DPC, or is in the process of doing that?
You can do it. It's very scary to think that going into business on your own is an impediment to possible success. It's difficult to know that you might have to compete with hospital loan systems or insurance-based systems. But the truth is, if you can keep your overhead low from the beginning, have a good plan, and have help from organizations like Medlion or the American Academy of Family Physicians, there is actually a very viable model that exists as long as you plan for it properly, and it's very rewarding to not have to answer to anybody else but your patients. So my advice to anyone who's thinking about doing it is to absolutely do it. I still own my company 100% today. I've done it without any investors, and even though our case is unique in its success, if we can do it, other doctors can as well.
Well, thanks for joining us. What's the best way for people to get in touch with you if they have any follow-up questions or want to learn more about Medlion?
Sure. So they can go onto our website, www.medlion.com. For the telemedicine device, it's www.medwand.com. Our office is, we handle both calls, but our office number is 855-211-3223. And they're welcome to see how we can help them in any way. Our email is info@medlion.com, and if it's a physician, I personally get involved to see how I can help them, and then we turf them off to the right team members, but it'd be a pleasure to help anybody who needs that assistance.
Very good. Well, we'll put a link up to all that on the website. If someone wants to get in touch with you, they can go there, conciergemedicineradio.com, and find links to Medlion and MedWand and some more information about you.
Great. Thank you.
Cool. Well, thank you for your time, Dr. Qamar, and we appreciate it.
Thank you very much, Taylor. It was a pleasure speaking with you. Thanks for having me.
Hey guys, this is your host, Taylor Pearson. To give you a little background on the show, after seeing my dad and sister, both physicians, struggle to find a good resource for how to transition from their traditional practices, I launched Concierge Medicine Radio to create a resource to help physicians and healthcare professionals launch, run, and grow patient-centered direct pay or concierge practices. If you enjoy the show and want to help us spread the word to other physicians and healthcare professionals, it really helps us out if you'll leave a review on iTunes. I know the iTunes interface is a little clunky to say the least, so we put together a quick guide on how you can leave us a review at conciergemedicineradio.com/review, or you can go to conciergemedicineradio.com and click Spread the Word.
Thanks for joining us today at Concierge Medicine Radio. If you found today's show valuable, we'd love it if you spread the word by leaving us a review on iTunes or sharing it with your friends. To see notes on today's show, please visit us at conciergemedicineradio.com. While you're there, leave us your email to hear about all upcoming episodes.